not the usual crop, and I have had some interesting bits and pieces. But so I'll just, if you fancy, I'll just show you some images.
Yeah.
But are we sharing?
Yes.
Okay, so I'm just going to run through anything. This is a pretty typical Achilles tendinosis. So there's nothing really exciting about it. I tend to look in short axis a lot. You know, I always used to look in this long axis of the Achilles, but actually I'm much more interested these days in looking at the internal architecture in short axis.
So I would like to have your mind just basically talk the chatter that you would be looking as your eyes would screen through what we call an elevator scan of the short axis. You know, I'm always intrigued to see that spiral. I'm also taking a look at what the research shows in a couple studies about the homunculus, the representation of which muscle bellies go to what part of that. What happens in your mind? Are you seeing medial gastrocs and soleus fibers as you look at it? Or are you just looking for echotexture of pathology?
No, I'm looking at the architecture, and this isn't probably the best scan for looking at that. I might sit down at some stage this week and pick out some good scans where I've gone through and you can see the pathology in different parts of the tendon.
I would love that. I would absolutely love that. I'm seeing.
Homogeneous.
Say that one more time.
It's all pretty homogeneous, and I haven't really gone far enough up. But if you take this, so if I can go back to that. This is the Achilles, yeah. Here, when you're in this mid portion, you can just see the stuff on the that's the left side, isn't it? Left side of the screen at the bottom is all heading right, and the stuff at the top on the right is all heading left.
Yes.
Oops, that's not what's meant to happen. There we go. As it goes, and that's you're seeing there the internal architecture. And that spiral through.
Yes.
Now, when you look back at, and we'll talk about it another time, but when you look back, if you go up the aponeurosis of the Achilles, and one of the things I'm looking for as I go up is that the point at which there's clearly two layers, because first of all it flattens out, but is into one thick, solid piece, like you're rolling out pastry. So you roll it out, it becomes a very flat but quite thick piece of aponeurosis. And then beyond a certain point, you actually see a filament between it, a nice bright line between the two layers. And the soleus layer is much thinner, typically, but is quite clearly visible. And that's how you pick out your plantaris tendon.
Yeah, what you just said needs to have some context with it, and I'd love to have you find those. I think what I heard you say is that as you watch the Achilles tendon start to thin out, that it will look like that it is a single layer of bright tissue, and that homogeneous bright tissue will give way to where you'll see an interface, almost making it look like it's bilaminar, and the lower tissue would, I'm going to guess, be gastroc. No. Yeah. What's that?
Soleus.
Yes. So that lower one would be that, and that's, right now with your Carl's or whatever, he put that article out on the gastroc tear and the various nuances of that tear separation. It would be a real valuable thing for me to at least visually understand what you're saying.
Yeah, let's have it. I'm going to just try. I've taken it off just because Achilles. I'm just going to see if I've got a video to hand. I won't spend too much time on it, but and it's an empty. Let's go kind name, which is MP. 4. Achilles. Yeah, we should have. Let me just share this again. There we go here, and let's just see what we get. So have you got my
Yes.
page up?
Yep.
Oh, why did that just stop? I just had. Which is MP4. And so I'm just going to flick through some of these and just see if this gives a. Okay, that's not a bad example there. Yeah, did you see? Can you see that?
Yes, I did, and I think I'm seeing what you're talking about. But talk me through it again.
Okay, so here we're in the Achilles, and this area is pathological. Yeah,
Meaning
so
that it has a darker color to it.
Yep.
Yep. Okay.
It's low echo, and as we follow it out, you see that same bunch of fibers normalizes and moves to the right.
Yes. Yes. Yes.
Yeah. So if you go over on the left, superficial, heading to the right, superficial, and that's down into the insertion.
Yes.
Yeah. So we come back up, and as we go proximal, you see those fibers now. And what I want you to do is to think first of all about this bit here, because the pathology is going to be here. So if we ignore that for the moment, you'll see this becomes a homogeneous, sort of almost stingray sort of shaped aponeurosis.
Yes.
Yeah.
Yes.
A little bit less normal on this side, but still looking at that right side as we go up, what you get, in fact, I'm going to take your mind off that because it's clearer here. Do you see this aponeurosis here?
Yes.
Yeah, that's soleus aponeurosis, and that's gastrocs aponeurosis. Yeah, and as we go distally, so we come distally down, it then stops being different. You see, you go to there, and there it's the same. So there's only one layer. You're going to have to take my word for it there. And then as we go proximally, we go up the calf, you suddenly got 2 layers, just evident at this point here. See, there are 2 layers there.
There is fascia forming between the soleus and the beginning of the gastrocs, or are we just now seeing it, or what is it?
No, what you've got is, if we go to, if I stop sharing and I draw it for you, it's probably the easiest thing to do. And you'll have to forgive me if this is. So you've got your Achilles tendon there. So attaching down here into the calf, into the heel. Yeah. It comes up here and it gets thinner and thinner and thinner. So it gets thinner and broader, but it's still one structure. Yeah. This is in long section.
Yes.
You get beyond a certain point and it actually becomes divided. So you've got 2 layers of fascia. Yeah.
Yes. Yeah. I'm understanding your words. The
picture's not great.
The long strands of the tendon are compartmentalized into 2 different locations.
Into 2 bands. So it's one band.
Yes.
And then it becomes 2 bands.
Okay.
And you get a blending. So and at that point, if you ever get into a cadaver section, what you will see is that it's one tendon, then it's one aponeurosis, but beyond a certain point, you can actually flap the soleus and the gastrocs apart.
Okay.
Okay. So it goes
How far from where it does this bifurcation to where you can flap it apart, or is that what this is showing? You can flap it.
Showing.
Okay. I'm with you.
That flapping apart is like almost like a bunch of bananas, but they're all joined up. Yeah. So that's what you're seeing here, but you're not seeing it terribly well here. This was just the first one that came up there. I don't know whether you can see that that line there
Oh,
is also.
I'm not sharing your screen. I'm on the drawing.
Yeah. So let's go back and share the screen. It would be lovely to share multiple screens. That would be amazing. But then you'd have to share it on. Right. So as we come distally, and I just lose the quality of the scan at that point. So if I come back to there, this is what you're looking at. This is normal. And this is soleus aponeurosis, which makes the superficial surface of soleus becomes the aponeurosis. Yeah.
All of
and
that.
This is the gastrocs.
All of that meat below that, is that soleus or flexor tendons?
No, well, this will be soleus and then probably flexor tendons underneath that. But the soleus, if we follow it back in, you'll be able to tell.
All right.
No, that's all soleus. That's all soleus. It all comes together.
All right.
So this is a part of one of the intramuscular aponeuroses within soleus.
But it has this thick fascial blanket on top of it. The aponeurosis on top the soleus.
Yeah,
and that's what we're starting.
Yes, but it is quite thin compared to the gastrocs.
Yes.
Gastrocs is much thicker at this point, and then your plantaris just fits nicely between them. That little.
Is that what you're showing me?
Yep, that is plantaris there.
That is these are the tips that makes it all worthwhile to you, because or to me. Let me ask you one more thing. The darkness above the plantaris tendon, is that contractile fascicles or is that fluid-filled fibers?
No, this is just normal fascia.
So this is normal fibrous tissue.
Normal Achilles aponeurosis.
Okay, that's not distal pieces of muscle.
No, that the muscle comes in there.
Right there. See? Okay, I just saw that. Yep.
Muscle over the top, and then I lost my little cursor there.
What is the John Leddy catch-all for the white things that show up there? Is that fibroadipose? Is that intramuscular septae? I want to know what your buzzword is so I can be the disciple.
What you mean? These bits here?
Yes.
That's just the intramuscular architecture of the. They're the bits of aponeurosis, for want of a better word, fascia, that actually make up the infrastructure of the muscle, and you follow these, and that was a big turning point in my scanning. Was when I stopped looking at it as noise inside and started actually following these, because I would sit. I still do. I will sit when I'm scanning a muscle, particularly a difficult muscle to understand, and I will watch where all those dots are going, because they drift across the screen. You can see them drifting across.
Yeah.
And this carries to the tendon. These are all the fibers coming together. And I always
long ropes that are lifting that giant in that one. They're all pulling to that huge thing. Okay.
Yes, they're all pulling to that huge thing. But the way they're going, and I don't know why, but when I first saw it, what it made me think of was a train running through a desert and thousands of children running towards this moving train, and they're all sort of running like this and joining up.
And the train is the central tendon, and all the children are running to the central tendon.
Yes, all the things just running into this moving train, moving along.
Yeah.
And so that's what I see when I scan these things. But you're looking for that sense, and when you're in a muscle, that's what I do. I run the probe over in short axis, and I get a sense of where things. And if I'm following a muscle and I'm in short axis, but the fibers are running in a different direction, you can turn and follow them. But sometimes, if you are following the muscle already, but they're going sideways across the screen, that's telling you where because they're almost like airplanes flying in, and they're all joining in to where the tendon is forming. So when you come down a muscle like semimembranosus, so you're scanning down the thigh, so you're following the thigh, but the fibers are whirling to the side, and they form this little C-shaped, or like celery. I always think of it as a piece of celery. the sort
I'm
of
with you, man. I'm
the
with you.
sleeve
Yeah.
shape
Yeah.
as it goes in, but you're seeing them all being whooshed in and collected, even though the tendon muscle is going this way at you,
Yes.
but the
Yes. Yes.
fibers are swirling round and
Yes.
forming on the edge and coming through. And it's
Phenomenal.
and by but by running the probe over, that's where the dynamic bit is. As you run, you'd only see it as you scan through. You don't see it on a still picture, but you get that swirling sensation. And that's what draws your eye across to where everything is going. There's that one. There's the tendon. Anyway, so, and this is a classic case of, do you see this pathological tissue here?
Yes. Yes.
Yeah, you can get a sense of, it's not entirely reliable, but you can get a sense that's coming from those gastroc fibers here. You see how you go back to where you see the pathology.
Yes.
And then you go whoosh, and then you can ascribe it, and I don't really know what the value is, but it's coming, those fibers, when you follow them back up, they're coming from this part of the gastrocs. And so I would ascribe this as likely to be relating to the Achilles fibers of the gastrocs and of the medial gastrocs.
Yeah. No, that's actually brilliant. That to me, that's very helpful. On your very first image that you gave me this evening, I'll put it in your context. In your very first image that you gave me, on the long axis, there appeared to be, that there was vascularity into the complex of the whole Achilles tendon. Give me your take on the so what of that. Clearly, there's people who say that there should be no circulation going into the Achilles tendon, that represents an inflammatory process in the peritoneum, and that are you, as a diagnostic interventionalist over there, is it more of a so what to you, or what does it do to you when you see that? Because am I not right to say that histologically the tendon should not have vessels in it? Is that correct?
I am not sure that's wholly true. I don't not. I've read this and that, as have you, and I am not sure the whole story. You get this in tendons. You see it in tendons that are pathological. You don't see it generally in tendons that are not pathological.
Why don't I get a darkness?
Now, that doesn't mean.
Oh, go ahead.
That doesn't mean that they aren't there in tendons that aren't pathological, because there will be some vascularity, or at least there is some fluid moving in and out. Now that may be not as organized, not as obvious, and not on the scale that you're seeing when you see color flow. And that's the way I think of it. I'm sure there is very little in an adult that will not be in some way repairing or in some sort of healing process. I would have said in the body, any normal person, their day-to-day activities, I'm sure, causes some attrition. So I see the vessels. The literature suggests that its significance is very ambiguous. However, when I talk to my patients, there seems to be quite a strong correlation between their symptoms, the currency of their symptoms, and the amount of vascularity. To the point where what I do routinely is I scan something with a patient who was talked to me, told me, usually complained quite a lot about the pain in an area. And then I scan them and I see the pathology as you do in this case. But I don't see very much color flow in it. And I turn around to them and say, how has it been just in the last few days or just in the last week or so? And when I don't see very much color in it, they almost invariably say, well, you know what? It's been a bit better recently. And when I see quite a lot of color there, it tends to be they then have this story that actually it's as bad as it's ever been, and it's really bothering them. So despite what it says in the literature, what I get from my patients, reliably enough, so I've come to sort of deliberately look for it, which is always a bad thing, but I see this direct correlation when patients are better symptomatically, just going through, whether it's a short phase or just the start of actually turning around. And that tends to be, I see patients very late. They don't come to me a week or a month. It's usually 6-8 months into a problem. And they're sometimes on the mend, and sometimes they don't quite realize it because they just don't believe it. But I see this on thing. I see the same grayscale pathology, but just a lot less vascularity than I would normally do. And this
Go ahead.
Yeah, and this was a relatively mild. This is in a nearly 90-year-old female. This is quite a thick.
That's where I wanted to go next. You brought up the grayscale that doesn't seem to change, but you could actually see that the color flow does change based on whether they're having an acute flare or a recent aggravation, or that they're in a down phase. So let's talk just a little bit about the actual, I guess the word I've heard is fusiform or football shaped, morphology there. You're saying she's 90. You're saying it's large. That's a phenomenally sized that's an amazing 90-year-old to me. But what do you do? What do you make of it? And do you feel that there's any value in somebody saying, "Oh my goodness, my work here is not done until those fibers are parallel"?
No, I would be very surprised if we see significant improvement in the shape.
You'd be very surprised to see significant improvement even after she's gone a year or two without pain. You would expect that this is what it would look like in her heel cord.
My best guess was that this would reduce in size as she gets better, but not to the point where it looked normal.
Okay.
I'm not sure, and again, I don't do a lot of longitudinal stuff, but I don't think these things ever become normal. I think they become better, and over time you do see changes associated with that. But I would expect this is big enough, and if you look in the short axis section, which I think was earlier on, it is quite thick and homogeneously thick. And
well, I would not have said 90 on that, buddy. Was she 180-pound German?
Nope.
Was that right? Wow, that's amazing stuff. Now, the next question I have for you on this too is: would you be able to say that in the longitudinal view or long axis view that would be soleus fibers? Would you be able to say it does look as though it's specific to the soleus, or is it hard to be able to say that?
No, I would say that I'm looking at that and I am not seeing any sort of geographical variation. If you take this point here and you split it in half,
yes,
and you look at the top fibers and the bottom fibers, and then as we go out, they are, all the fibers are getting narrow. All of it is thinning in both directions. There isn't one section that looks like the architecture is the same all the way through. So this is a homogeneous swelling of the Achilles.
Yeah. And what would you say? It's would we talk metabolics? Would we talk is this issues of diabetes or cholesterol, or we don't know?
The history was she thought someone ran into the back of her ankle with a shopping trolley.
So what do you do? Say, yep, that could happen, or do you say, oh, I've got some PRP here. Let me put something like that in there. What do you end up doing? Mostly counseling?
Mostly counseling. Probably a slight heel raise.
Okay. Okay.
Take the pressure off.
Yeah.
You still do some loading, but patients have already failed loading before they get to me. I'm not seeing anything significant. If you look at the color flow in something like this, there's not a lot of that. The soft tissues underneath are not particularly abnormal. And certainly in the 21st century, we're not going to want to jab her with too much steroid. A rupture of Achilles, not that I think a small dose of steroid would necessarily facilitate that, but you wouldn't want to have a ruptured Achilles in a really old patient if you didn't need to, as that would, the consequences.
In the last 2 or 3 years, there's been at least one fairly strong study that at least seems to cast doubt on that great fear that we had that a corticosteroid even was responsible for spontaneous heel cord ruptures. Do you think that the real world, however, I mean, do you have 5 stories in your career of injections back when you used to do heel cord injections that all of a sudden they snapped for no apparent reason?
I don't have any stories of Achilles tendon snapping, but then that's not really my population for doing intervention in those. We do have anecdotal evidence that you do get rupture of tendons after that, and remarkably, it's been in a particular vulnerable one for us has been flexor carpi radialis, which you wouldn't expect, and this gets injected semi-regularly around in our parts because we would not uncommonly inject the scaphotrapezium joint, and that communicates with the flexor carpi radialis. And we have known cases of that rupture, and that's not a weight-bearing joint, not a weight-bearing tendon. So we certainly think that there is some merit in it because it is not a common rupture. And so for us to see it and to see it post-injection,
yeah, no, that makes perfect sense.
Not always when they look rubbish to start with as well.
It makes me feel as though putting a corticosteroid alongside of those long-strand collagens is like putting canvas in the sun, that where it just becomes more brittle, less capable of taking a tensile load and sharing it amongst the fibers, but hitting the end of elasticity much faster so that we get a more of a burst issue. I don't know any of that, but the fact that you're sitting here and as you talk about it, I have growing envy of you guys over there because you have this nuance to your scanning that always has in your back pocket the ability to follow a piece of metal the size of a, I don't know what, down the plane of what you're imaging. And not only that, but you've got this entire vault, what you just talked about like it was nothing, talking about the scapho triquitrial whatever, and of course
I call it the scaphotrapezium joint. Other people give it different names.
and you just and you say, well, of course we would want to do that. And, yeah, of course, nothing in my mind, but you're visually seeing yourself delivering that. That's a personal issue. However, as you what you basically told me is that it is you own the fact that indiscretionately injecting an owie with a corticosteroid is something that a person should take pause at, and that there's only certain times when a person should use it because of its destructive or catabolic effect on collagen, and that is a common belief, right?
Yes. Yeah, and it's certainly one that I am reasonably convinced of. Now, I appreciate that the numbers are not necessarily huge, and the studies that you see, it is just really difficult to study because everyone is seeing relatively small numbers, apart from one or two of the really major players are seeing relatively small numbers of these, and so the numbers of failures in any cohort is really small, and patients, certainly in the UK and presumably elsewhere, don't necessarily go back to the person they saw when they did. If they were properly consented, then they're not going to start suing or complaining about it because they were told it was a possibility.
No,
but
I hear you.
They're going to choose to go and see someone else. So a lot of our failures get lost to us.
Gotcha.
And so we are fortunate where we picked up on these are in places where we get by nature of the services we run, we get to see our failures. And so
do you guys use ketoprofen? Do you guys use any non-steroidals? Was that ever a wave or anything like that, as opposed to using corticosteroid, putting in ketoprofen as an injection?
I've read about it. I've never met anyone who's ever done it. Certainly not on this side of the pond.
But what about what they use for like prolotherapy? Is that a word over there? I mean,
yeah, yes.
What is it that they put in to do prolotherapy, and is its goal to literally create a fibrotic mass that scleroses?
That's the way it's been described to me, but
you don't use it.
I have never used it, and
would the health service pay for it?
I think very occasionally it has. It depends. Our system is complicated, as all systems are, and it's not something that is generally available. But any one service, if they think they can justify it in terms of cost and efficacy, can decide to do it and provide the funding for it, but out of funds they already have. But if it's not, but they'd be reluctant to do that if our oversight organization called NICE doesn't say that it's a viable option. So we have an organization that assesses all treatments and says whether they think they're appropriate and therefore should be applied within the NHS.
I'm going to move now to a topic that I want to spend some time with you on. Throw me to where I'm seeing you bigger. There we go. Good, because I want to see your face a little bit more specifically. I would like to have your take on a particularly, well, I guess I just want to throw it out to you and get your take, because I value your opinion, and let me just set it up like this. I have an association with a brand of scanners, and in the process of trying to strategize on how best to bring in the musculoskeletal point of care providers through an educational process as part of trying to provide with a scanner a package of educational material. The company that I'm talking to is wanting to provide education to the consumer who's going to buy the scanner. And so, of course, they send me an email that says, hey, we're talking to this organized, good named educational provider, online content, and what, how do you feel about that? And this is the disconnect that Greg has with that. I guess because my mind sees, let me just throw it out there, smug, ultrasound, or MS, whatever Stuart Wildman's was, Sonoskills. There are some efforts within the U.S. Now, Advanced Musculoskeletal Center. People are putting online content and are commoditizing this online content. And I will tell you that I don't think that's a bad thing, because exposure to stuff is at least exposure to stuff. And if it's well presented with diagrams and all that, a person will at least begin to gather echo texture of of ligaments and tendons and aponeurosis and things like that. However, here's Greg's disconnect, and this is why I'm setting it up to you. Do you feel that there ever could be an educational process, instead of it being ventral ankle, and here's what we scan, and lateral ankle, this is what we scan, and instead of it being somewhat of an anatomically driven imaging educational process, is it ever, my mind says that we can start to say to the therapist something as simple as, if you can touch where it hurts and put enough gel on it and hold the probe up to it, and we could teach them the whole concept of the worse optimal worse idea. Is there ever a time when a person can, like you did, look at the children running to the train and look at, are there areas and patches of these dark clouds that are building? And I don't mean to get that stupid, but can we not say that black patches matter, or that black masses matter? That if, I guess what a simple way of saying it would be, is there not credible presentations of pathology that instead of saying, all right, here are the, here's the anatomical dissection of the now 3 parts to the ATFL ligament, that I'm never going to see, I don't know how many percent, and with a probe, maybe only a Phillips something else, am I going to be able to take it and move it 15 degrees to see these other fibers? But if the player just sprained his ankle and I can see a piece of white with a lot of building black, do you follow what I'm saying? Is there not, don't you feel that you could provide to the common hands-on therapist something that we could look for without having to go through the varying levels of demonstrated ability to see all of the components of the deltoid ligament? I guess that's what it's coming down to, is I know there's nobody out there doing it, and the only person that has the information in their head is people like you. But I do believe that if they, a torn muscle is going to show up darker than a non-torn muscle.
It's a ultrasound. You've been in it for so many years. It's a subtle game, and the struggle that students have is that there is when you get past looking at the most obvious things, that there is so much ambiguity in what you see, and until your technique becomes stronger, that it doesn't really matter. From my perspective, it doesn't matter what the educational material is. It is it's all, I used to say to my students, if I'm doing a training day with them, I say, I'm going to move all around the body. I'm going to be showing you how to do this, showing you how to do this, getting you to try this technique and see this thing and this thing and this thing. I don't really care what you're looking at. What I'm trying to do is teach you to manipulate and to appreciate what's happened, that changes of texture. The only reason I move from part to part to part is because you're all enthusiastic musculoskeletal clinicians. And if I just sit there with you pointing the scanner at a box of different colored grays, your attention span is going to be 0. Whereas if I take you from the supraspinatus to the Achilles to the ATFL to the psoas tendon, your attention level is going to be higher, and that's the bottom line. when you're teaching ultrasound, you're not teaching the front to the brain. The front, everyone who does this has got degrees, has competitively got on courses that where everyone else in their class couldn't get on them. So they're bright people with the bright fronts of their brains. And the academic side is just like walking off a log. The knowledge base even is like walking off a log. The difficult thing is the driving the car, driving the airplane. It's the back of the brain and the hand and the eye seeing things, and the ability to, for me, the most important thing is that skepticism and that thing. And this is just, and so everything you see out there, all the educational tools, all the rest of it, it isn't all theatre, but it's all the superficial. What really matters is what goes on. Good night. But that's not what from my point of view, when I'm teaching people, that's not what I'm trying to do. I'm not trying to teach you how to do ATFL. I love showing people how to look at ATFL and all the other ones, but that's not the point. The point is trying to get this understanding, this feeling for the image. But even more than that, it's getting that hand-eye coordination, because that you can't appreciate grayscale if your hand doesn't automatically adjust to that optimal picture. And that's where I struggle. That's where I struggle with spending hours making fancy presentations to put out there and go and lecture on stuff, because I don't care about that. What I care about is getting the students to work on and run through, when you're running through the muscles, just going backwards and forwards until your hand automatically takes you there. And that's where, and that's not I don't think that's a package, and which is why I can't be interested in trying to produce some sort of program or things like that, because that's not the most amazing thing I ever saw. Was I was at a conference, and a lady I used to know used to sell Toshiba ultrasounds, Wendy. She was working for a company that had developed a trainer, so where you could hold the probe and it would have on the television screen, there was a mechanical arm, so the probe could feel what you were doing with it, and it would just ask you to match a sphere to a sphere, or alter a shape to match a shape. And it was just teaching that coordination thing. And I thought that was really clever. I thought it was amazing, because that's what ultrasound is. Sorry, I just closed the door. They're chatting away next door. But yes, there's in terms of educational packages, these are, I think they have value, but they are only ever a part of the thing. It's always this is the dressing, this is the adverts. The actual meat of your ultrasound training is just getting on there, scanning, and getting, first of all, the hand to move unconsciously, and second, to have that concentration and appreciate, and just sort of really digging down at the detail. It's when you get that image of the Achilles, not looking at the Achilles and saying, I'm seeing a big Achilles, amazing. It's pathology. It's going and watching the tiny dots move round and saying, is that continuous? Have I then changed my angle of my probe to be absolutely short axis on those fibers, not on the Achilles tendon, but if I'm appreciating those fibers, am I actually adjusting that? And that's difficult to teach, difficult to put into a package. And we can rant about it, but you just have to put the students in a situation where they need to do that, and that's hard to do without me standing behind them.
Yeah, no, I hear you. I just, I'm every day I have an encounter with the frustration that I can't seem to light the fire under people for this passion that I have. And I had a 31-year-old female rock climber who came in and has has the inability to even demonstrate how bad her wrist Hertz that was injured 2 years ago in an auto accident, and it was fine up until 2 months ago or a month and a half ago when she was rock climbing and held her wrist for a prolonged period of time in one position and tried to go a different route up, and all of a sudden felt a growing pain in her wrist, and it's just so incapacitating now that in order to demonstrate it, she had to use her other wrist. And so, they did a volar plate because of achilles type fracture 2 years ago after she, stopped the car coming at her. And so she has the hardware on that kind of thing. Well, I went long axis over the FCR, the flexor carpi radialis, and I was looking for this peanut shaped scaphoid. And I found the scaphoid, and right in the middle of that peanut area, it had shifted, and dark fluid was coming up, and there was complex material in various stages of turning callus formation. And because of that metal device there, she was just in building pain. And I'm sitting here going, it was because nobody ever showed me how to image the scaphoid. Well, obviously, I listened to some videos, and so maybe they must have. But I pull out my anatomy book, my app, and I look at it and I go, crud, we shouldn't be seeing a shift in it, that the actual echo change from that. Is there not the ability for us to say, if you're looking at bone, kids, we shouldn't see this, and this is going to have this eruption, and if we're at 4 to 6 weeks afterwards, there's going to be this cloudy material around it. And I think about this young lady, and even now I have in front of me this report I'm putting together with arrows to show these doctors that's the scaphoid, but they've got to take my word for it because they don't know what they're looking at. And there's a ring down, on the radius, and it comes to the end of it, and I have all this stuff up. Mark, let's try John. It's not like we haven't been talking for months and months. I guess my frustration is there's no gold standard study they're going to order. The MRI, because of that metal stuff, X-rays aren't going to show it. Maybe a CT scan will show it. I have to put this together so that the hand surgeon that did her previous plating is going to believe that some physical therapist in some small town actually has a device that's going to show a compromised scaphoid in a wrist that he's going to question whether or not he can even do an MRI. Now, there's so many overlying complex issues that I'm sharing with you here, but the point I guess I'm trying to make is a therapist who understands how to scan, putting that beam width, to make that periosteal line as narrow as possible. When you're getting one part of that scaphoid optimized and the other part is thrown off, and we see dark and we see stuff like that, is there not some level of this is what bad looks like, boys and girls, as opposed to saying, I don't know how to do that.
No, I don't either. Because for me, you can make anything look like anything. It only takes a single. Every time I scan a scaphoid, I think it's fractured, and then I optimize my view, and it isn't.
That's so valuable to hear you say, John. What do they call that in case of?
Sorry, I'm back.
There we go. I thought it was the rapture, John, and you just been taken.
No, someone was warming up some milk in the microwave, and I think that's next to the router, and so that's why we were losing the audio.
I can let you go, buddy. You got on early for me, but
yeah.
I'm intrigued because we have such. Take a look at myself and say that's reasonable for you to think that in this slice here, but here's the problem. If it would be that, we would expect to see a dome of fluid, or we would expect to see. That's the kind of stuff I've got to be vulnerable enough to do with you. I got to work on that, man.
And to be honest, if anybody, if you're ever scanning with any old hands like me, you will get that when you are, well regarded. Well, I stand behind anybody, and it's not because I'm better than they are, but it is so subjective, and I see something different to what other people see on the scanner, and mine is probably better than people with less experience than me, and I will see less than the next person down the line. We are all just on a line, and hopefully all getting better or more changing. But I look over people's things, and it isn't that they're necessarily wrong or you're necessarily wrong. What I'm doing is I'm seeing what I see, and which is why I don't let my students aren't allowed to agree with me. It's really important that after the first couple of months, they're not allowed to agree with me.
Because what do they have to do?
Well, it's because they have a different set of experience. All the people who train with me usually have lots of clinical experience, so they have different experience. They have different expertise. They are seeing something different, and so if they are just accepting everything I say, then they're not thinking about it. Because if they're coming to the same, if they spontaneously listening to the patients, looking at the scan, if they are seeing what I see, then the chances of that are just zero.
Okay, I hear you.
But other than occasionally, they've got to be coming, so if I'm saying this and they're not saying, well, actually, I think something different, then there's something wrong with the way their head is working, because ultrasound's not like that. You have to, if you can't question what I think, then I can't be confident you're questioning what you think.
All right. I want to be held to a 10-minute presentation of one of the studies that I did that particular week, and I'd like to also have you see if you can't collect some stuff that you can share with me. I need to